Carsten's a associate professor from Royal Prince Alfred Hospital, and also the Chris O'Brien Lifehouse Hospital, which is a semi-private, semi-public centre of excellence in the centre of Sydney, who specialises in otolaryngology. Basically, he's a head and neck surgeon, but the new head and neck surgeons are all ENT surgeons these days, whereas the old days general surgeons used to subspecialise in head and neck surgery. So Carsten's a pretty high caliber, hardcore head and neck surgeon who does major head and neck surgery, ranging from, you know, the big stuff to the finesse laser surgery for laryngeal lesions. And I think you may have done some robotic transoral robotic surgery as well. So he's got quite an impressive portfolio and 20 years of experience. But more important than all that and all the gadgets he's got and the toys he can play with, which are not that relevant to tonight's talk, is his experience in the South Pacific. He's done a fair bit of work in Papua New Guinea, mostly, but elsewhere as well, and Southeast Asia. So I think we're quite privileged to have Carsten on the program. We've also got Saper Lajavati, who's a young plastic surgeon from Macquarie University Private Hospital, who may contribute something on, if time permits, on the radial flap recon, if that's not covered by Carsten. Also on the panel, we were going to have James Kennedy. James Kennedy was going to talk about his own sort of unique experience with treating lip cancer in PNG, but he's got some reception problems, so we may not be able to do that. So I think we should get started, Carsten. I'll let you chair the session and I'll give you sharing rights. Yep, you should be able to share now.
Now, can you see my screen?
Yep.
Great, hang on.
Can
you see that?
Yep, can see it. Oh, this session's also been recorded. So if there's anything that needs editing, we can edit that later. If there's anything that you don't want presented, just let me know and I'll delete it.
Yeah, sure. All right, look, thank you very much, everybody, and particularly Gary for, introducing me to this group and asking me along. It was really kind of incidental. Gary and I ran into each other at one of the hospitals that we work together. And we were just trying to help a patient recently from Vanuatu. I guess my background is, as Gary said, I'm an ENT surgeon. I finished my training in 2001. I then did head and neck oncology fellowships in Toronto, Canada, and also in Europe. And my main practice has really been head and neck oncology. And over the past 6 years, I've been very fortunate to work at a place called Chris O'Brien Lifehouse, which is a new cancer centre right across the hospital, the road from Royal Prince Alfred Hospital. And it's quite a unique model in that it's a private hospital, but it has a public-private partnership that's not for profit. So the budget for the public hospital for head and neck oncology, and in particular other types of oncology, is actually transferred to the institution. So it's this unique model where I think we can really truly deliver equity in healthcare delivery. And just from my point of view, in our head and neck department, we're a big department. We have 13 head and neck surgeons. We have 6 oncologists, medical and radiation oncologists. We have 5 surgical fellows at any one time from all around the world. We have registrars, allied staff, research staff. Importantly, we have a huge amount of operative resource, and we do 80 sessions a month or in excess. So that translates to 40 full days of head and neck operating every week. We have sort of grown to become the largest head and neck cancer hospital, certainly in New South Wales. And if you look at the numbers here, these are complex head and neck cases performed per hospital. and the numbers are at the bottom, and you can see that, you know, barely the majority, half of cases, half of hospitals meet the benchmark of 25 per year, but you can see Lifehouse out here consistently beating the pack. These are the sort of second busiest hospitals, which are St. Vincent's, Liverpool and Westmead, and Lifehouse does 2.5 to 3 times as much. Our vision has really been not just to look after patients in this beautiful new building, but also to develop outreach programs and outreach clinics. So here's a map of New South Wales, and there are a number of outreach clinics that we've established. And this, I guess, part of my my experience, and Gary introduced that nicely, is I've spent quite a number of times and years going to Papua New Guinea. So in Papua New Guinea, I've been to Port Moresby, I've been to Lae, I've been to Goroka, I've been to Rabaul, and you know, Paki Malumi, it was a great contact, and now I understand he's actually the CEO of Port Moresby Hospital. And I was really privileged to see them in action and help them, and learn. And learning is really a two-way street. It's not just about us teaching, but also learning from our colleagues. So I have had quite an interest in, in teaching across the world. And I guess I've taught a lot around North America, Europe, and also Asia, and places like Myanmar and the Philippines. Gary sort of charged me with a fairly basic topic, and that's really just to introduce head and neck cancer. Well, head and neck cancer is quite a complex disease, because unlike prostate cancer or organ-specific tumors like breast or colon, it's really a kind of a heterogeneous group of malignancies that really have one thing in common, and that is that they arise within the head and neck region, and that region being bounded by the dura above and the pleura below and the spine posteriorly. It is actually quite an uncommon cancer in the Western world, and males predominate, and the median age is a little bit older, in excess of 50 years of age. Although things have changed with time, and I'll explain that. Where are these cancers? Well, they develop in the upper air digestive tract, and the upper air digestive tract really starts at the front of the lips and sort of stops at the cricopharyngeus, or the upper esophagus. And includes the oral cavity, which is really bounded by the lips, and the anterior tonsillar pillar. They're the oropharynx, which is the soft palate, posterior pharyngeal wall, tonsils, and base of tongue. They include the larynx and the nasopharynx. But also they include the major salivary glands, the parotid, the submandibular gland, the sublingual glands. Importantly, the thyroid gland comes under into our disease group. And we must not forget cutaneous malignancies. Now, this is not a common thing that you would find in the South Pacific, but certainly in Australia, where, you know, white man was never really meant to come and live. You know, skin cancers are, make up a huge number of the cases that we operate on. And we know that skin cancers predominantly develop in the sun-exposed regions of the head and neck. So there's a lot of work to do in terms of resecting primaries and also regional disease. We must also not forget skull-based tumors. This is a cross-section of the pharynx. You can see here the larynx at the back of the tongue. This is the base of tongue. The nasopharynx, which is kind of behind the soft palate, is an important region for cancers, and particularly in Southeast Asia, you know, nasopharynx cancers, which develop right next to the eustachian tube, is actually a really common cancer, and it relates to the Epstein-Barr virus. The incidence of cancers is, as I said, is quite low in the developed world, but I'm just using one of the cancers as an example. Oral cavity cancer is actually quite a common disease in Southeast Asia, India, and absolutely Papua New Guinea. And when you look at a map here, Melanesia is really the epicenter for the development of oral cavity cancer. And when you look at the incident rates, you can see that they are world leading compared to any other region, and particularly women, you know, really lead the world in developing mouth cancer, particularly in Papua New Guinea. Why does this happen? Well, the big issue is betel nut chewing, right? So 400 million tubes in the world. And there are lots of variations of chewing in PNG and Melanesia. The staghorn calculus, you use the mustard stick and the areca nut. In other places in Taiwan and in India, you mix that in with tobacco. And that is incredibly carcinogenic. You know, it develops a very alkaline environment. It develops a condition called submucous fibrosis, and it really leads to a very high rate of oral cavity cancer in those people that chew. But the traditional risk factors for oral cavity cancer, and particularly other types of cancers that cover the upper air digestive tract, are clearly smoking and alcohol. What we have realized, particularly in the Western world, that the HPV virus is incredibly carcinogenic and has led to an absolute explosion of the incidence of tonsil cancers and base of tongue cancers developing, particularly in young men, non-smokers. The other etiologic agents that cause head and neck cancer, particularly in the white population in Australia, is clearly the UV exposure, the sun exposure, but immune suppression plays a huge role. What are the pathologies? Well, the predominating pathology that develops within the upper air digestive tract and the lining is going to be squamous cell carcinoma. Other types of cancers that we see are clearly thyroid carcinomas, papillary thyroid carcinomas, follicular carcinomas, less commonly medullary or poorly differentiated, and quite uncommonly anaplastic cancers. Salivary glands are very common, and they often arise within the parotid gland and the submandibular gland. And also, we must not forget the minor salivary glands that are located within the palate. And the incidence of cancer is actually inversely related to the size of the gland. So in the parotid, you're going to be more likely to face something like a pleomorphic adenoma, which is benign. But a tumor within the minor salivary glands on the hard palate, that's going to be more likely to be something like a mucoepidermoid carcinoma or adenoid cystic carcinoma. We must not forget the hematologic malignancies, which are often the great mimickers, such as lymphomas. And the most common cancer below the clavicles to metastasize to the head and neck is actually renal cell carcinoma. But I have seen colon cancers in the paranasal sinuses and also cervical cancer and breast cancer. The vast majority of patients with head and neck cancer develop with a neck lump. And we've got to understand that when somebody presents with a lump like this, and it is malignant, it is going to be most likely a secondary, and most likely that primary is going to lie above the clavicles within the head and neck regions. So depending on the site of the lymphadenopathy, it gives you a clue to where it might arise from. So one of the really important things is we've got to be able to speak the same language. So in terms of looking at the head and neck anatomy, the head and neck anatomy by the American Head and Neck Association some years ago has been divided in different types of levels. We have level 1 underneath the mandible. We have level 2 underneath the angle of the mandible, level 3 further down, level 4 at the root of the neck, and level 5 being the old posterior triangle. Level 6 has been described as that being the paratracheal lymph nodes, which play a significant role in thyroid cancer. And also level 7 lymph nodes are those located just above the innominate artery and make up the superior mediastinal nodes. So it's very important that in our own mind, we sort of, whenever we see a lump, we kind of describe that lump according to the neck level that it may lie in or arise in. You've got to think, you know, when somebody presents with a neck lump and you have a male older than 40, you're going to think malignancy. It's not going to be inflammatory. If you have a child, they're going to have inflammatory lymph nodes, and they're incredibly common. If you have somebody from a Southeast Asian background and you have a lymph node, particularly with hearing loss and nasal obstruction and epistaxis, you've got to think nasopharyngeal carcinoma. Clearly, you've got to elicit a history of smoking, alcohol abuse, and betel nut chewing, and importantly, a history of past medical problems. So, for example, this guy, it's a lay-down misere. He's a white sun-exposed Caucasian who's had skin cancer surgery in the past. He's got a mass developing rapidly within his left parotid, and he's a cardiac transplant patient. So he has got metastatic disease from one of his squamous cell carcinomas. So just by looking at him, you know what the story is, you know how you're going to treat him, And importantly, you know that his prognosis is actually quite poor. So when we take a history of a neck lump, we've got to always ask ourselves, how long has it been there? Is it causing any pain, or is it growing? Importantly, we have to interrogate the upper air digestive tract. And the upper air digestive tract is pretty boring. It only does 4 things. It's a conduit for air and airway, and important for breathing. It's important for swallowing. It creates the voice, and it's important for sight, sounds, and smell. You know, and if you have a head and neck cancer that embarrasses any one of these functions, it's going to point you towards where the problem might lie. And so here, in somebody that has a cancer at the back of the nose, they often get hearing loss on one side or nasal obstruction. They might, late signs might be headaches and cranial nerve palsies due to lateral rectus palsy. The oral cavity, a lot of times these patients present with a benign ulcer, but they might get some pain. They might have some denture problems or bleeding. Very rarely do you then start seeing pain from bone invasion. Voice box cancer, you know, the first thing that would change if there is any change to the vocal cord lining is you're going to get a hoarse voice or change in voice. So often those cancers judiciously get picked up pretty early. Late signs generally lead to airway obstruction. Tumors that lie above the voice box or in the oropharynx or the hypopharynx, they often present with unilateral pain in the ear. So if you have somebody with pain on one side and there is no issue within the ear or any other obvious problem, you've got to think cancer in the supraglottis or above the voice box. You've got to think of cancer in the base of tongue. Head and neck examination is clearly the standard, and we all need to learn a system how to evaluate the head and neck lymph nodes, but we also must learn a system of how we examine the neck lymph nodes. And I'm sure most of you who are very experienced in looking after patients have your own system. When you're looking in the oral cavity, you've got to have a good headlight and generally have a couple of tongue depressors and systematically work your way through the lower gingiva, the upper gingiva, the cheeks, the floor of mouth at the front, the floor of mouth on the side, looking at the mobile tongue, making sure you have a good look at the hard palate and the soft palate, closing off by looking at the tonsils left or right and the posterior pharyngeal wall. The classic examination that I will go through is a flexible fiber optic nasendoscopy, where we stick a telescope in the nose and examine the upper air digestive tract. Ultrasound is a very important and simple investigation that can give you a lot of ideas about what's going on in the neck, whether you're dealing with a solid mass, whether you're dealing with a cystic mass, and then importantly, it can facilitate the guiding of a needle biopsy. Now, certainly in the Western world, we're incredibly blessed with a lot of resource, and we have a whole bunch of things like CT scans, MRIs, and PET scanning. But a lot can be achieved with a good ultrasound and simple X-ray, and particularly when you're dealing with mouth cancers and OPG. So this is a bit of a slide of the sort of upper air digestive tract cancers that we see. You can see here an endophytic ulcer in the left lateral tongue. You can see here a picture of a patient with a tonsil cancer here on the right-hand side. This is a picture on laryngoscopy looking at the vocal cord and the larynx. So this is the left vocal cord, that's the right vocal cord, and here you can see a lesion. This is looking into the nose on the right-hand side. This is the eustachian tube orifice, and it is obstructed by a cancer called nasopharynx cancer. This is a lady who's presented with a very neglected right parotid cancer, a mucoepidermoid carcinoma. And here you can see a guy with quite a large goiter that really doesn't provide much of a diagnostic dilemma. As I said, here are some more pictures, particularly this lady here. This is a lady that I saw in lay. You can see here she's got a lymph node within the left side of her neck. She's got a terrible buccal cancer cheek, and the poor thing is being fed with an NG tube. But you know, you can see here this hard palate cancer, and this certainly would have shown its face by judicious examination, and the fact that the dentures wouldn't be fitting. Here's another tongue cancer on the left and a flora mouth cancer, and quite a subtle small cancer here on the gingiva. And this guy was a lawyer from Sydney. So just to sort of show you what we see at nasendoscopy, I'm just trying to advance my slide and hopefully this works. Somehow it hasn't worked. Here we go. So this is where we have fiber optic endoscopes, and this is something these days. These are fairly high-tech instruments, and you know you would be familiar with colonoscopes or gastroscopes for looking at the stomach and the colon. Well, these are just tiny gastroscopes that we stick in the nose. And one of the great things these days is that we are getting more and more disposable units being created. And I think this is going to really allow the widespread use of this technology. So this is a tiny telescope that goes inside the nose, and I'll show you now here. So this is a lady sitting at my desk, and here we go in the left side of the nose. This is the septum on the left and the turbinate on the right. This is the floor of the nose. We're going right all the way back into the, until we get to the nasopharynx. And this is ordinarily very well tolerated. I think there was a bit of a problem because it was a bit tight on this side. So I went in on the other side. You can see here the septum on the right, inferior turbinate, and the middle turbinate superiorly. Again, we're going on the floor of the nose. This is much easier to go in. And the first thing you'll see is the eustachian tube orifice, which is here. And nasopharynx cancers would happen here. Then we go south, and this is the soft palate from the other side. We come over the top. Your first thing you see is the epiglottis and the base of tongue. Here's the vallecula on the left and the right, and you can get a really good idea of what's going on in the base of tongue. In the distance, you can see the larynx. These are the vocal folds. You've got the vocal cord here on the right-hand side, the left-hand side. And at the back, you can see the opening to the esophagus. And here, these are the what we call the piriform sinuses, which are next to the larynx and behind the thyroid cartilage. So this is really a very good standard examination, very simple, very easily tolerated. You can even get an idea of what's going on in the upper trachea. And this is really a standard workhorse. And I think a number of companies, and I've sort of worked with a number of companies, have developed disposable units like this. And I think they're going to be of widespread use more and more, not just in our country, but all around the world. This is a whole bunch of patients that we've treated in our regional centres, you know, people with terrible skin cancers, people whose noses we had to take off because of skin cancer. This is a terrible tongue cancer in a lady, and again, a parotid tumour. This guy here had a big parapharyngeal tumour on the left-hand side, which was malignant and required a mandibulotomy and resection. When we talk about the aims of treatment should always be cure, and we need to consider the primary lesion, but importantly, we also need to consider the neck lymph nodes. And we always need to balance the morbidity versus the benefit. And we need to consider the impact, not just of the cancer, but our treatment on the upper air digestive tract in terms of all the functions that are outlined before. We do need to think about the teeth, cosmesis, and importantly, quality of life and ultimately survivorship. And the best outcomes are achieved when we practice in a multidisciplinary team. We're not an island, but we're a team. There are surgeons, there are medical doctors, there are pathologists, basic scientists, dietitians, speech language pathologists, radiation oncologists, social workers, etc. And here, this is a paper I wrote when I was a fellow in Toronto in 2004. You know, we need to go through a systematic way of when managing patients, and particularly those with mouth cancer. You know, we've got to understand that we've got to take a history, examine, we need to appropriately investigate and stage the cancer. We need to perform an endoscopy and assess the primary and importantly the neck. We need to present the patient with the appropriate stage to the multidisciplinary team. And then we need to discuss what type of treatment might be appropriate, whether it's what type of resection, what type of reconstruction, and other types of treatments such as adjuvant radiation or chemotherapy, or if these patients are potentially a candidate for a trial. And importantly, we must not forget rehabilitation in terms of all the upper air digestive tract function and the patient's quality of life. And then we need to systematically follow these people, because we know that 80% of recurrences with head and neck cancer develop in the first 2 years. So it's very important that we do see those patients often very regularly and empower them to seek help if they're worried about any issues in the meantime. One of the key ways of prognosticating and working out the outcome of what we do, and also comparing our treatments, is in terms of staging the tumor. And you guys would all be familiar with this. There is a T stage, which is the tumor, the primary, and that's often the size criteria, up to about T3, and then whether it invades adjacent structures, T4. We've got to look at the neck lymph nodes, you know, whether there are no lymph nodes involved, whether there's one, whether there's more than one, whether there are things such as extracapsular spread, and then also the M stage with these distant metastases. And that will tell us whether the patient is stage 1, 2, 3, 4. Because the important thing is, when we're allocating treatment, as I said, we need to balance the risk versus the benefits, and we need to consider patient factors, tumor factors, and institutional and surgeon factors. And when you look at mouth cancer, the principle of treatments are such that early disease, stage 1 or 2, we should try and get away with one modality. And certainly in oral cancer and mouth cancer, surgery is preferred. But in larynx cancer, you might prefer radiation. More advanced disease, stage 3 or stage 4, are going to require multimodality treatment. There's going to be combination, whether this is chemotherapy and radiation, or surgery plus a combination of radiation and chemotherapy. And we must not forget that those patients who are not curative, that there are often options in terms of trial enrollment, and palliation is a very important mode of treatment to provide as much comfort to the patient and family as possible. When we're looking about surgery, we need to think about removing the primary, and in particularly in mouth cancer, it's performing glossectomy or partial mandibulectomy, but we need to consider neck dissections, and whether we perform neck dissection on one side or both sides, whether we perform selective or comprehensive dissections. We need to consider securing the airway by performing elective tracheostomy, and also by securing their nutrition. And we often do that by nasogastric feeding, but sometimes if you know it's going to be a long time before they're going to eat, inserting a percutaneous gastrostomy is often the most palatable and best thing for the patient. In terms of reconstruction, there's a reconstruction ladder. You know, we can close things primarily, we can allow things to heal by secondary tension. There are types of grafts, free grafts, and then there are types of flaps which are either random or actual and can be local. For us in Australia, and certainly in the Western world, the standard workhorse for head and neck reconstruction has become free tissue transfer of soft tissues, bone, or a combination. Adjuvant treatment, as I said, is made up of external beam radiation or chemotherapy or trial enrollment. It is important to always have a plan when you perform surgery. And as an example here, we're currently writing a textbook on head and neck dissection. This is one of our diagrams that I've developed. This is a left parotid showing you the incision that we make, the fascia that we need to raise. The yellow is the parotid gland. The posterior belly of digastric is one of the key landmarks when you're doing this surgery to identify the facial nerve. So when you do parotid surgery, in your own mind, you've got to consider where you're going to put the incision, how you're going to elevate the flap, identify the posterior belly of digastric, because this is going to lead you to the facial nerve, and then work out how you do the facial nerve dissection. And there are certain concepts that we have developed leading to tumor removal, and then how you close the neck. It's absolutely the same in thyroid surgery. So when you look at here, this is a diagram looking from the right side onto a left thyroid lobe. This is superior, this is inferior. You know, the key thing is exposure of flaps. Identify the isthmus. I like dividing the isthmus early. Then the first thing I often do is divide the strap muscles, certainly the sternothyroid muscles. address the inferior pole and then the superior pole, systematically dissecting this, then going lateral to the lateral pole, divide the middle thyroid artery, and then deliver the thyroid out of the neck, and then approach the recurrent laryngeal nerve, follow that up to Barry's ligament, and then complete your surgery by dividing Barry's ligament off the trachea and close the neck. So, you know, whatever we do in surgery and head and neck surgery, it's always really important to have a plan. And clearly this is very important for our trainees, but certainly also, you know, for more experienced surgeons, it's always good to stick to a plan just to make sure you're not running into trouble. Gary, are you happy for me to keep going, or? I can't hear you. Nod if yes. Okay. So this is a right tongue cancer. You know, one of the simple ways of dealing with that is just excising the cancer with a good margin and then performing primary closure. I would say now, certainly in Australia, we would be putting in free flap tissue here in order to improve the mobility of the tongue. But, you know, a simple way of dealing this is just to excise it. One of the other ways... Sorry, can you hear me? Sorry. One of the other ways of approaching a tongue cancer is after you've completed a neck dissection, you can actually perform what's called a hemilingual release, where when you divide the posterior biliodigastric, the styloid apparatus, the lingual nerve, and the hypoglossal nerve, you can actually deliver the tongue into the neck and then perform a very good glossectomy, getting good margins. Now, closing this defect is going to be a little bit more difficult if you don't have free flap tissue, but there are other flaps, local flaps like the submental island flap, or a pec major that would certainly help in separating the oral cavity from the neck. This is a total lingual release where you can deliver the entire neck, the entire tongue into the neck, and then you can basically, you know, aggressively resect these tumors. I mean, these are pretty desperate situations where we're performing, you know, 3/4 glossectomy. This is a young 40-year-old who had a 3/4 glossectomy, and this is what his flap looked like in rehabilitation. And although his speech was, you know, clearly impacted, he had intelligible speech and was actually able to maintain a normal diet. When you're seeing invasion of the mandible, that becomes a little bit more difficult. But you can see here the OPG is actually a good, simple mode of investigation to look at invasion of the bone. And you can see here the sculpting of the bone. Now, we in Australia would practice segmental resection, as you can see here, and fibular reconstruction. But, you know, this kind of cancer, you could get away with potentially just doing a marginal mandibulectomy, leaving at least a centimetre bridge, and then either covering this with a bit of buccal fat or leaving it to granulate. Lymph node dissections are really important. So particularly when you're looking at oral cavity cancer, you know, the lymph nodes are involved. They're underneath the chin, level 1, level 2, and level 3. So, you know, I would always say that any cancer that has any depth to it, you know, is going to, and they don't obviously have any lymph nodes, you should resect those lymph nodes electively, because you're going to find microscopic disease. And recent studies have shown that even selective neck dissections do improve survival. Clearly, if you have lymph nodes that are palpable, then you know, you should perform a therapeutic neck dissection. And often it would mean a comprehensive neck dissection and an aggressive neck dissection to make sure that you get good disease clearance. Because in the end, we know that lymph node disease is the most significant prognostic factor in head and neck cancer. So if you're going to control somebody's disease, you're going to only control it if you control the lymph node disease. In terms of reconstructive options, as I said, there are a number of options of primary closure or secondary healing, but you look at this buccal cancer here on the right-hand side. This was excised right through the buccinator and left to granulate, and it healed nicely. One of the great things is using buccal fat to close either buccal defects or posterior maxillectomy defects. There are other types of flap like the nasolabial flap, which is great for flora mouth cancers. I mean, clearly you're going to have edentulous patients. Otherwise, you're going to have a dead flap. There are other types of flap like the facial artery myomucosal flap. The submental island flap is something that's popular. However, I'm always a little bit worried about the oncologic effect in not clearing those lymph nodes properly. And then really the workhorse is the pec major. And as you can see, that was a bailout flap for tissue which necrosed after neck dissection. This here is a palate flap. So here was a defect in the posterior maxilla into the soft palate, and we would rotate broadly the front right part of the soft palate into the defect. As I said, with bone, certainly if you don't have a free flap ability, I think the aim is really for marginal resection. Sometimes you can even do a simple resection on one side and let the jaw swing off the contralateral jaw. And that is actually not an unacceptable way to deal with patients, particularly when they're edentulous. You know, there is a trend to use simple flaps and then simple plates and then cover it with soft tissue. But in my experience, they tend to extrude and cause quite a lot of issues. In terms of head and neck cancer, the prognostic factors are patient, tumor, and treatment. And as I said, the most common prognostic, most significant prognostic factor is the state of the neck nodes. And particularly when cancer spreads out of the lymph nodes, that is generally a very poor sign. However, clearly age and gender, you know, can play a role, but importantly immune status. And certainly in our region where we have a lot of patients who undergo transplants, you know, those patients tend to do a lot worse. In terms of tumor factors, apart from the nodes, you know, clearly the stage, and importantly, other things like how many lymph nodes did you actually get out in the neck dissection. And we have published on this, and particularly when you're looking at a selective neck dissection, you want to get out at least 18 lymph nodes out of one neck, because if you get any less, then that generally tells you that the extent of the dissection hasn't been that sound, and that does actually have a prognostic factor. Clearly, treatment, you know, whether you've got good margins, whether you've treated these patients with multimodality, and importantly, experience and volume. So we published a paper with our colleagues in Brisbane that showed if you treat less than 20 mouth cancers or tongue cancers a year, and this is Australian experience, 10 to 20% of patients will be dead because of that lack of experience. So the corollary is, if you're a high volume mouth cancer surgeon, you will have a survival advantage in your patients over 10 to 20%. So experience and volume is clearly incredibly important. These are some of the stage groupings from the American Joint Council of Cancer. And again, that clearly shows that stage is an important prognostic factor, with stage 1 doing an awful lot better clearly than stage 4. So really, in summary, head and neck tumors are a difficult group. They're a heterogeneous group of pathologies. They have a massive impact on the patient in terms of form, function, and survival. And it's often not the cancer, but the treatment is complex, multimodality, and has significant adverse events. Disease-specific survival is stage-dependent, and we feel that the best outcome is achieved with getting to these patients early and treating them in high-volume centres. So thank you very much, and I'd be certainly very happy to have any questions.
Well, that was a very compact, well-organised, but simple and clear, compartmentalised talk, Carsten. I originally wanted to do head and neck surgery and got scared off by smart people like you and chose colorectal instead. I'd like to know how the colon cancer got to the paranasal sinus, but yeah. It's probably not the most important question I have. The most important question I have is, would you be able to come to the South Pacific and increase the ability of the local surgeons to get beyond that learning curve in neck dissection? Because it seems to me that surgery is the only modality available in the South Pacific, and early cancer is currently, correct me if I'm wrong, but generally treated just with its removal without a neck dissection. And I think neck dissection is one area where where care can be improved without the use of prostheses and equipment that is expensive and unavailable. Radiotherapy is just not available. Chemotherapy is not available oftentimes.
Yeah, no, look, I spent, like I said, I've spent many years going to PNG, and I was very fortunate, to meet a lot of great people, a lot of skilled people, a lot of people who do extraordinary things, with limited tools. My life's actually pretty easy because we've got everything. It's just very simple on our end. But you're absolutely right. I think the way you're going to save lives is by doing neck dissections, because you can resect the cancer, and even small cancers, and you spend all this time looking after them only for them to fail in the neck and then die miserably. So I think neck dissection is incredibly important, and I must admit, I'm pretty aggressive when it comes to treating neck disease, particularly in oral cavity cancer. So look, in terms of your answer, of course, I'm delighted. I had this great. We had these great ideas in PNG, and for lots of reasons, and particularly COVID, they sort of fell off the wagon a little bit, clearly. But I'd be very keen to reinvigorate. If I can be of any service. And certainly it wouldn't just be me. I come with a big department. I have some unbelievably skilled surgeons in my unit. So, we could certainly support any way possible the South Pacific, with activity on the ground, with, virtual meetings like this, with hosting people. So look, the sky's the limit, and you know what? I'm quite excited. The other thing that I would really be very keen about is getting flexible nasal endoscopes into the South Pacific, because I've spoken to some of the industry and they would be very happy, and particularly with the technology now, I think that is definitely doable.
What about a pediatric gastroscope? Will that suffice?
Yeah, mate, how big is the bloody, the scope that we stick in the nose is usually about 4 or 5 mil in diameter. And, I do sometimes put in bronchoscopes if I don't have anything, but, again, it's just a matter of educating and teaching, and we'd be very happy to do that, But, I think it'd be, I tell you right now, I think with certainly some of our contacts, it would be very, very easy to support people around the South Pacific with simple nasal endoscopes.
So it'd be good to hear from Sapir, Elvis, and Linda. Linda Fenton's.
Hi, Linda.
Hi, Carsten. How are you going?
Linda's a head and neck surgeon from Maitland who's done a fair bit of thyroid surgery in mainly the Solomon Islands. Yeah. One thing, Linda, I'd be keen for your opinion on this. There seems to be a trend towards total thyroidectomy. I'm not sure how accessible thyroxine is in the South Pacific, but for benign disease, nodular goiter.
Yeah, that's what we were mostly doing surgery for, was for benign disease and hemithyroidectomy only. As you say, certainly in Gizo, I was told that there was virtually no access to thyroxine there. Perhaps in Guadalcanal, there's a bit more opportunity to get some thyroxine, but it was really just hemithyroidectomy. And for benign disease, that can actually give you a good amount of relief. A lot of the surgery we do here for totals is actually for cosmesis, because they have the ability to take thyroxine afterwards. But the other problem that prevented us from doing total thyroidectomies was the lack of ability to get a calcium done promptly. And if you can't check a patient's calcium post-operatively, you need to leave 2 undisturbed parathyroids in there. So really at the moment we were limited to hemithyroid, but that will give good symptomatic relief. It may not necessarily fix the cosmesis of a big goiter, but it will give a lot of symptomatic relief and can be done safely and simply. And certainly the surgeons I was working with were doing really, I mean, I was just there to cheer them along. They didn't really need me. They're doing that surgery very nicely.
Yeah, I invited Douglas Picacho to come on this session, but he's retired and he's in a remote province with poor access. But I take my hat off to Douglas Picacho, who taught all the surgeons in Solomon Islands how to do thyroidectomy and does it very well.
Yes, yeah. I thought that was very good. The main thing I was helping with was the carotids. I think the learning curve on that is quite steep. You need to do a lot to get good at carotids, but it's not to say it can't be learnt. And there's obviously a lot of need there in Solomon Islands for that surgery to be done. But I think they do rely a bit on us coming across to help with that.
Yeah, I think that learning curve is quite a limiting factor, and that's where having the expertise of yourself and Carsten on a regular basis would be awesome. I thought the incidence graph, Carsten, just showing how big a problem it is in the South Pacific, really hit the mark. And this is where we need to be focusing surgery in the South Pacific, because it's uniquely a problem there. Elvis, what's been your experience, Elvis? Elvis is a general surgeon from Papua New Guinea, the Highlands, SOPAS. Do you do much head and neck?
Hello, can you hear me now?
Yeah.
Okay, thank you very much for the presentation. Very, very inspiring. I really learned a lot of things from the presentation. I'm actually in the Highlands of Papua New Guinea. You know, in Papua New Guinea, when you are thrown into the provinces as a general surgeon, you become an expert in everything. You have to do everything from the top to the, from everything. So I came here as a young surgeon, but then in Papua New Guinea, it's very difficult for you to refer a head and neck patient to any other hospital. It's so difficult because you have very limited number of head and neck surgeons. So I sort of like learned to do this thing myself. So over the years, I've been able to learn to do all the thyroid and thyroidectomy, cervical clearance and all this stuff. So from my experience, what I realized is that challenging thing in Papua New Guinea is the adjuvant treatment, radiotherapy and chemotherapy. We can do a lot of surgery, but if we don't have this other treatment, it's very difficult. So from this presentation, what I learned from this presentation is that if we can have visitors like the expert ENT surgeons that can come and help us to learn more, to share the experience with us on how to do it properly, then it will be very helpful in the long run. But now we're just learning from the books, and once in a while we go to Port Moresby, we say we took James Knight Power, and we learn a little bit of things from them. But I think it'd be good if you can have a regular visit and share your experience with us. I think that's all.
Thanks, Elvis.
Where are you in the Highlands? Where?
I'm in the Enga province.
Right. Yeah, I've been to
Mount Again, it's 3 hours.
Yeah, I've been to Goroka. In fact, I think I spoke at one of the General Medical Council meetings at Goroka many years ago. And I know Paki Malumi very well.
Yes, he's
Mike.
Yeah, that's right.
Hey, Sapir, we might hear from you. What do you think about the feasibility of plastic reconstruction for head and neck surgery in a place like Honiara? Is there a role for it, particularly the radial flap, or as Carsten was saying, the pec major flap?
Thanks, Carsten, for a wonderful presentation. I learned a lot as well. That was excellent. I think definitely in the context of head and neck surgery, having some tools in the toolbox for reconstruction is definitely needed in a lot of cases. And I think the slide Carsten had on the various steps in terms of the complexity for reconstruction is quite a useful way to go about this. So, you know, some people call it the reconstructive ladder or elevator. Basically, you know, you have your simple procedures. There's a lot of things that can be allowed to heal with secondary intention. I actually wanted to ask Carsten his opinion about what types of tongue or tongue-based resections could potentially be left to heal secondarily, and how one would decide that. And then you're going to potentially graft some defects. So a lot of head and neck skin resections can be grafted, and then using local flaps where possible. So there's a lot of flaps described for lip resection. So, you know, reconstructing up to almost the total lip resection can be reconstructed using advancement flaps from the cheek. So basically bringing tissue from the sides to reconstruct the defect. Same for nose or eyelid or ear. So I think quite simple techniques that are very easily accessible to surgeons, and you don't require any fancy techniques. And then regional flaps for bigger cases or salvage cases. So the workhorse, as Carsten mentioned, is the pec major. That can be done as a primary flap or as a backup flap. So I think definitely worthwhile. I think we can organize plastics on some of the head and neck trips, and the surgeons to be comfortable raising a pec major flap either with skin or just a muscle flap. If you're separating the oral cavity from the neck, pec major with the skin can be utilized up to the level of the orbit, actually. So there are techniques to make the reach of the pec major extended, so you can actually get the pec major to reach quite high on the head and neck. So very, very good flap, very robust, and good as a salvage option as well if you know, someone has a saliva leak or already had attempts at other reconstruction. Now, I think free flaps have their utility in Australia. They're a lot of the time the first option that we go to. You know, so a lot of tongue resections in Australia might just get a radial forearm flap as a default option, but it doesn't mean that there's no other options for that reconstruction. Now, I think given that you need a microscope, they're quite long procedures. It does need to be in a center where there is appropriate facilities. Now, I'm not sure, Elvis, is there microscope facilities in Port Moresby?
I'm not really sure. I'm not really, I haven't attached with the ENT team, so I'm not sure.
So,
and Honiara, I'm not sure, Gary.
well, the ophthalmic surgeons, I don't know what they use there, but can I just ask, is two to three times magnification loops, that doesn't sort of cut it?
Not for free flaps. It's a bit hard, especially doing the vein, because, you know, obviously once you raise the flap, you're under time pressure,
right.
And if you then struggle with the vein, I mean, for someone who does a lot of them, maybe you can do it with loops, but it will be tricky. Now, not saying that, you know, that's impossible, but I think having good regional flaps like a pec major, it's I think a really good skill to have for those resections. Now, Carsten, I just wanted to sort of get your thoughts on allowing some of these more the oral cancer or tongue to heal with secondary intention. What's your thoughts on that?
Yeah, no, thanks, Eva. So look, I think you can let an awful lot granulate. You know, I think we sort of throw in flaps because we can, and a lot of times I don't necessarily think we need to. The reason why we do throw a lot of flaps in, because ultimately it leads to less tethering and better functional outcomes. I think where you do need a flap is if you're going to do a concurrent neck dissection and you're going to have a communication between the mouth into the neck, because having a salivary leak going into the neck is not going to be pleasant. So, and particularly the problem's going to be a floor mouth. If you've got a tongue cancer in the mobile tongue, you can actually resect that and close it and keep the neck separate. But once you get a cancer that requires more floor mouth resection, then you're just going to come into the neck. Now, that said, if you maintain the mylohyoid, and you can sometimes use a little bit of a local flap, like a sternocleidomastoid flap to plug it off, but it's not ideal, you know. So sometimes in that scenario, you might want to stage it. You know, you cut the floor mouth cancer out first, wait 2 weeks, and then come and do the neck dissection afterwards. You know what I mean? But you're right. You know, we let a lot of things heal. You know, we do a lot of robotic surgery where we resect half the base of tongue. We let that granulate. We resect the whole lateral pharyngeal wall. We let that heal. You know, a lot of times palate tumors, you know, when you see pleomorphic adenomas of the palate or cancers, particularly if it's on the hard palate, you just cut it right down onto bone and then just put a pack in and let it granulate, you know. And I think there's an awful lot you can let granulate, even things on the gingiva, right? I mean, you know, once you've done like a marginal resection, you know, by lowering the bone, the soft tissue just falls in. So sometimes you can even close it primarily. And the buccal fat is just an unbelievably good flap, right? Because when you incise go through the buccinator, that tissue just falls out, right? And it is amazing how much comes out, and you can actually move that around the oral cavity quite well. The problem with putting it in the floor of mouth or tongue is length and also teeth. Now, if you're a dentulous, that's no problem. But if you've got teeth, that's going to be a bit of a problem. I think the nasolabials are excellent. You know, you just raise them, you make a hole, you pop it through, and then you divide it later, just like an Abbey or something. You know, that works really well for anterior floor of mouth. But again, the problem is if you've got teeth, you know. But you're spot on, you know, there is just a lot of things you can let granulate in. So, you know, there's a lot of things you can do. And I think you're totally right. And I think that's maybe what you should consider, is teaching people how to do a PEC major. Do some good diagrams, you know, and work some videos, because that is a great flap to use, you know.
And then a lot of those cases, you can try to stage these or do a local flap, a FAM or a nasolabial, yeah. And then if you then do get a leak, then you have your PEC major as a salvage if you don't want to make it a big case. So I think being able to do a PEC major and then some local flaps around the oral cavity, I think FAM flaps are quite good as well. So I think the surgeons here can look that up, described by Australian surgeon Julian Prebaz, Australian by heritage, but working at Harvard. So that's quite a robust flap, very good vascular supply based on the facial artery, raised on the inside, basically with the mucosa, and then that can be used floor of mouth or palate.
Yeah, it can be inferiorly or superiorly based, so it's actually quite mobile. Yeah.
Well, thanks very much, everyone. Time's sort of running out, so I just wanted to thank you, particularly Carsten, for a really concise, excellent presentation for an introduction to head and neck cancer. I found it quite entertaining and a little bit too graphic for my liking, but anyhow, I just want to, before we sign off, mention that we do have another head and neck session coming up, and I would certainly like to invite Linda and Carsten to this session as well.
Very happy to.
Yes.
Great.
Is that the one in February? Yeah.
That's right. 22nd of February.
Because none of us are going to Auckland now.
Okay. Oh, gosh, that's right. Thank God for Zoom. Anyway, thank you very much, everyone. This will be recorded and put up on the Daisy web. I'll send you a link to it all. I think there's a lot. It's a really good resource to go back and sort of review in detail. Thank you, Carsten.
All right, mate. Thanks,
Thank you, everyone.
Thanks, Carsten.
Bye.
Thank you.
Thank you. Bye.